If you want to know about sclerosants and sclerotherapy, you're in the right place. We're going to chat with world-renowned expert Richard Oliver. I don't know anybody who knows more about sclerosants and sclerotherapy than Richard. We will cover what is the best sclerosant, Polidocanol or STS? What is the best concentration for small veins? How should we dilute sclerosants? With water for injection or with saline? What exactly is an unlicensed use, and what are the medico-legal implications? Where on the body can sclerotherapy be used? What about sclerotherapy for facial veins? What about the consent process? What are the common reasons for complaint and dissatisfaction after sclerotherapy? We can speak confidentially, and we can edit it out and remove it.
I thought you were going to say that anything you say can be held in evidence and used against you in the future.
Tell me, before we start, are you happy to talk about the fact that STS is going to 0.2% is going to be withdrawn?
Yes, I've got that on my list. Yeah, and I was going to explain the reasons why as well.
Okay. All right then, because obviously some people who are starting sclerotherapy might decide to avoid STS altogether and just go straight with Polidocanol.
Yes, I can understand. Yeah, no.
Okay, and the other thing is, I don't know, you probably can answer this straight off the cuff, but Zola has asked me to ask you if we do dilute STS, particularly the normal, what should we be using? Normal saline, water for injection? Does it matter? What's the science? If you're happy to talk about that.
Yeah, I could talk about that, yes.
Yeah, that's the minimum micellar concentration, I suppose, isn't it, really?
Yes, yeah.
Okay. Richard, first of all, I want to say thank you very much. It's been a long time since we've either chatted or met. You've kindly put together a fantastic presentation, Richard. I mean, it's really deep, and it's very good of you to do that. I'm going to embarrass you, first of all, by introducing you as probably one of the most knowledgeable people about sclerosants, sclerotherapy that I know. I mean, you've always been there for me when I've had a query. I can email you with a silly question and you come back pretty quickly with the answer, often with a reference or your own personal opinions or that. I mean, I'm just very grateful. So I think this talk is going to be very helpful. I put it out on the Mastermind group that I have on Facebook, and I put a poll together. And I was just looking at it, actually. I'm just looking over my shoulder now at that poll. I told the Mastermind group that I was going to be talking to you. And I don't know if are you still in the group, Richard?
Yes, I did see the post. I haven't looked at it subsequently, but yeah.
Well, here's the thing. I've got the poll now. I can do a screenshot and share it. So this is my Mastermind group that I put together. It's quite a big group, actually. It's 308 people. And it's an amazing group of experts. I put this poll together. What would you like to ask Richard if you were there at the meeting? What would you ask him? And interestingly, the thing that they are most concerned about is liquid versus foam.
Yeah.
For Telangiectasias. Licensed use. Also, what is best? That was the second most frequent question. What's best, Polidocanol or STS? And here's the thing, Richard, which really surprised me, and I think you're going to cover this whether the audience likes it or not. What are the legal ramifications of licensed versus unlicensed, and how should we consent patients when we're doing sclerotherapy? I suspect, actually, when we look at it carefully, most practitioners, or a large percentage of practitioners, are using sclerosants in an unlicensed way.
Yeah,
and I think
that does happen.
Mean we need to, we either dilute it, or we foam it, or now with the new Varicose equipment, we can make microfoam, which is gaining a lot of traction in the sclerotherapy world. So I think this legal aspect and the off-license use is very important. But anyway, that's enough of me. You very kindly got a presentation that you're going to share with us.
I think the simple answer is, and I think that people who've used both agents and have done enough sclerotherapy would say that there is very little discernible difference in terms of the outcomes and the adverse events between the two sclerosants. but they are different mostly in terms of their potency. So the main thing to remember is that STS is about twice as potent as Polidocanol, and it's very important with sclerotherapy, whatever you're treating, is to use the appropriate concentration. And as Mitch Goldman, one of his statements in one of his well-known textbooks, the sclerotherapy textbooks, said is use the minimum of concentration to exert the effect, essentially. Because if you use too high, you run the risk of adverse events, and if you're too low, then you're under-treating the vein. So it's really choosing an appropriate concentration of sclerosants according to the vein that you're treating. And it's probably appropriate at this point that we mention that, as I've got on the slide there, 0.2% Fibrovein is equivalent to about 0.4% the sclerosants. It's probably worth mentioning also that it's public knowledge now that Krussler and STD Pharmaceuticals have joined together to become the force for sclerotherapy, rather than trying to compete against each other with, albeit really very similar products. And the decision has been made not because of the merger, but because of the fact that the 0.2% Fibrovein comes in a vial with a it's not a rubber stopper, it's a plastic stopper in the top, which has got rubber properties. The manufacturer of the current one is ceasing production and changing it to, albeit almost chemically identical stopper, but there is a slight difference in composition with one of the components. But because of that, to change over to a new stopper or to change that particular presentation into an ampule, the costs are in the hundreds of thousands of pounds. And so the decision has been made, now that we are working as one company, because Aethoxysklerol is available in an equivalent strength, is that we're not going to continue manufacturing that presentation of Fibrovein, which is going to be a shame for some people, but you can be reassured that using 0.5 Aethoxysklerol would be equivalent. And where the veins are particularly small, and we would sometimes advocate diluting the 0.2 further to 0.1%, there is a 0.25% Aethoxysklerol available. So it will make very little difference in terms of people's clinical practice, other than the box looks different and the Aethoxysklerol is all in ampules rather than vials. So we suspect. Sorry,
Rich, a bit of a delay. Is that new? My recollection is that 0.5% Aethoxysklerol was the lowest concentration. Is that new now that there's a 0.25%?
They've been a 0.25 for a long time. It's just not it's not been marketed in every country. Similarly to Fibrovein, we've got four strengths, but some countries are just not marketed because of either history or the costs of gaining the registrations.
Right. And will that 0.25% Aethoxysklerol be available in the United Kingdom?
It is registered, yes, and as far as I know, is now available, yes.
Right. So I know my colleague, Kathy McGuinness, who demonstrates at the BAS, I think she is demonstrating in May this year. And in fact, you're talking there as well.
Yes,
she uses 0.2% of STS and dilutes it down to 0.1%. So if she were to use the 0.25% Aethoxysklerol, that would be equivalent.
That would be about equivalent, yes. Yeah.
Yeah. Okay. Sorry to interrupt you there. So that's great news, isn't it? That I know worldwide Polidocanol is the most popular sclerosant, much more popular than STS, but there are people who are very attached to STS. In fact, I know that Ron Bush has written a paper to say that STS is the preferred sclerosant for telangiectasia.
Yeah, I think his studies were based on a lot of histology, which does show slightly deeper penetration into the vessel wall. I think in terms of clinical outcomes, you would find very little
Right.
between the two agents.
Okay. Good.
And of course, STS has, because it's a stronger, a more potent solution. It's a more harsh sclerosant. The 3% STS would be approximately equivalent to 6% Aethoxysklerol, which obviously doesn't exist. So for the large veins and things like recurrences, it would be much more appropriate solution to use.
Right. We are going to move across now to Polidocanol for spider veins, aren't we?
Yes.
Not yeah. Yes. Okay. So, would you like to cover the debate about whether we should be using foam or liquid for spider veins?
Yeah, it's quite a topical subject, obviously, because many have indicated that in your poll. It's something that has been done in France for many years, and the French have been using foamed sclerosant for spider veins for a long time, up until the year before last, when the French agency has essentially forbid the use of foam for treating spider veins in those low strengths.
Right.
So the French agency is the ANSM, which is equivalent to the MHRA here in the UK. And the thing that triggered that off is sadly there was a death following use of Polidocanol. There was a cardiac arrest, a fatal cardiac arrest in 2021. But dose used was only 4 mils in total of Polidocanol at the time. But the ANSM quite rapidly put out a memorandum to all healthcare practitioners stating the maximum doses that could be used, and also stating that they must only use the sclerosant as indicated on the license, which means that the lower strength sclerosants are not licensed for use as foam. And so pretty much overnight that stopped the use of foaming in small veins in France. And that was quite unfortunate for many of us, really, because probably about now 5 or 6 years ago, a study was started in France, which was sponsored by the SFP, the French Phlebology Association, which was called the Fovelite Trial. A trial set up, a randomized trial, a 4-arm trial to compare Polidocanol and STS, both as liquid and foam, which would have hopefully provided the answer as to which everyone wants to know is which is better, foam or liquid in spider veins. And it was, I think that the power calculation on it was a recruitment of about 200 participants. And I think it was stopped at around about 100 participants. So they have some results. It's underpowered. I did contact Matthew Josnan, who's the lead investigator of the study, just the other day. And he says that there is an intention to publish the results that they've got, probably in the Phlebology Journal. But it is going to be underpowered. But they do have a lot of other useful information in that study. So we still don't really have an answer as to, in terms of efficacy, which one of those is best. Previous to that, the only reasonable study was that of Kern from 2004, which was
you've got some slides of these, haven't you, Richard?
Yes. Let me. So that's. No, here we are. So that was the Fovelite trial, which I mentioned, that's the protocol which was published in the French Phlebology Journal, Phlebology with an IE at the end. So it is available online. You can actually read through the protocol. I think it's all in French though. But prior to that, the key study that people referred to was that of Kern, which was a 3-arm study comparing chromated glycerin, which is a chemical irritant, which isn't currently available in the EU or in the UK. And that, albeit a relatively small trial, and had 2 observers rating the differences, showed that the chromated glycerin actually showed slightly superior results in terms of satisfaction, although not significantly. And in terms of the observers, the foam and the liquid were fairly similar, not significantly different, although the chromated glycerin seemingly produced slightly superior results. And following sort of reviewing that trial, I just had a look to see if there was any other evidence, and there is a Cochrane review which was published in 2021. So it's Cochrane reviews. I don't know whether you know much about them, Haroon, but
I do read them from time to time. But tell me the background.
They are behemoths of information, and you can quite quickly get drowned in Cochrane reviews because they are sort of very academic, but they do serve a useful purpose to summarise clinical trial literature to give you an idea of treatment effects of many trials, and it's just useful to know that the Cochrane collaboration was really founded by Archie Cochrane many years ago, and it was his feelings that there were lots of papers being published, often showing quite contradictory results, and he didn't really know. It was very difficult to determine what the effect of a treatment was. And the first review was done on using steroids for preterm birth mothers to reduce the risk of neurological complications after birth. And the number of studies were done, and it showed that if you provided the mother with steroids before the baby was born preterm, then it reduced the complications in the baby. And that's where the Cochrane logo originates from. It's that particular study, and that's a forest plot of all the individual studies put together, with at the bottom a little tiny diamond that shows you the effect one way or the other. And so when we start to look at Cochrane reviews, the most useful part of them to go to are the comparisons, the comparison tables where they've done a forest plot that looks like this.
Ah, yes.
So
yes.
They look quite complicated when you first look at them, but there's a few things to sort of point out. The first bit is looking at the title to see what it's compared, and this particular Cochrane review is comparing the treatments, various treatments for telangiectasia, and this analysis table shows the comparison between polidocanol and other sclerosing agents for the resolution or improvement of telangiectasia. And so on the left, you have listed all the studies that they've examined. And in between there, you have data in terms of the numbers of participants, various means that they might have looked at, and then the relative weight of the study, which is the size of the study in comparison to the others. So those are sort of interesting data, but the best data to look at then is the actual forest plot on the right-hand side, which basically puts in pictorial form the data from each of the studies, and the length of the line is the confidence interval. So a longer line means the confidence interval is greater, so the sort of the effect of the study is, in terms of statistically, is not so great, whereas a shorter line means the confidence interval is a lot smaller. And then the little box that's put on the line gives you an idea of the sort of the treatment effect within that study. And at the very bottom, there is a large diamond shape which summarizes all of the above trials, and the size of the diamond and the width of the diamond gives you an idea of the confidence interval and the size of the effect. And the line that runs down the middle could be, in this instance, it's the mean difference between the studies, but it could be a risk ratio or an odds ratio, which are more complicated phenomenon to explain, and I'm not going to attempt to explain them now. But essentially, when you look at it, and very quickly you can look at it and see if that diamond sits one side or other of that line down the middle. You can look at the axis below and what it's indicating. So this axis says to the left it would favour other sclerosing agents, to the right it would favour polidocanol. That diamond sits bang in the middle, which means there is no significant effect from one or the other. So the interpretation of that is that it doesn't really matter which agent you use, and that's to me is pretty good evidence based on those randomised trials. The other thing to look at in a meta-analysis like this is the heterogeneity, and that's signified by the I-squared number that's situated there. So this was 0%, which means there's not very much difference between the trials in terms of the way that they're set up and the way that they've looked at the outcomes of their studies. So if the heterogeneity, the I-squared number is less than about 50%, then the heterogeneity is low, and you can basically have more faith in the results that they're presenting. There's no significant difference between the two, which is what that test for overall effect is telling you. So P is 0.91, so it's well above level of significance. So looking at that, you could quite confidently say there's not much difference between polidocanol and other agents that have been used, be that STS or chromated glycerin or hypertonic solutions. The next picture that I'm going to show you is comparing STS with other sclerosing agents. And again, the diamond is slightly larger, but it crosses the 0 line in the middle, which means it doesn't favour other sclerosing agents or favour STS because it's not significant either way. If we then look at other factors in this systematic review, you can look at, which is the next comparison I was going to look at. That was foam. That was laser versus sclerotherapy. And quite surprisingly, although people say foam sclerotherapy is the gold standard, that systematic review says that it doesn't favour one or the other, which is quite interesting. Although I think many practitioners who've tried using lasers for treating spider veins have said that sclerotherapy is superior. But what I wanted to show was in this systematic review that there's only 2 trials, the Kern study I mentioned, and then the Benigni study, which I think is a French study from 1999, a very small study. But the meta-analysis shows little difference between foam and liquid. Essentially, that's what the other sclerosing agent is actually referring to there. So there is very little difference between the two. So the evidence is showing that there isn't much difference between foam and liquid. The difficulty is when it comes to trying to get those on your license, and Mike Watkins, who's my colleague here at STD, was responsible for getting Fibrovein licensed in European countries back in around about 2010. There just isn't the evidence for the supporting the use of foam in the small veins. There's plenty of foam studies with using higher strength sclerosants in larger veins. That's not an issue, but there is just a paucity of evidence in these small veins, which is why neither agent is licensed at the lower concentrations to use as foam. So using foam would be an off-label indication, which I think we'll touch on in a little while.
Just for clarity, Richard, at what point do we say larger veins? You say it's licensed for smaller veins, but it's not licensed, but it is.
Well,
at what point does it become a larger vein? Are we talking about spider veins and reticular veins?
No, we're talking about varicose veins, more the truncal and accessory veins. So it's veins above sort of 3 millimeters plus in diameter.
Right. So just to summarize, just to summarize, to make sure I've understood you correctly, for small veins under 3 millimeters, there's no difference between Polidocanol and STS, whether you use liquid or foam. There's no difference.
That's what the evidence is suggesting so far, albeit it's a limited amount of evidence, but there is evidence there.
Right. And if you use foam for vessels less than 3 millimeters, that's an off-license use.
Yes, unfortunately, yes.
Right. Okay, good. Sorry, Richard. I just wanted to touch base, make sure I was following you correctly.
Yeah.
Right. Proceed.
Yeah. The next slide I put in was recently. It was the summary of this would have been published in Phlebology, and they've published statements from the UIP from for a whole raft of various venous interventions.
Yes.
And the one on microsclerotherapy has sort of muddied the waters slightly, because within that statement from the UIP, which is the International Phlebology Association, says that both foam and liquid sclerosants can be used for microsclerotherapy,
Yes.
albeit the foam off-label, off-license.
Yes,
but
I
it
saw
does,
that, and I was quite surprised by that.
It does say, though, the evidence-based studies comparing the two formats in C1 veins are lacking. So it's it's covering itself, but it's not a very useful statement in terms of legality, really.
No, and I've always had the view, and I've tried to defend this, that if we are using liquid and we're getting good results, why change to foam?
Well, I mean, that's what many people say, and I would support that, because the potential, and I think it's less than if you're treating the truncal veins. If you're introducing foam, then you're introducing the risk of the complications that are associated with foam, which include largely the neurological complications, which is a talk in itself, really. But
yes,
although many would say the risk is a lot lower because the volumes are much smaller, and the foam has got to go through a much more tortuous route before it finally reaches the deep circulation from a spider vein than it is if you're putting it into the GSV, for example.
Yes, but of course the criticism that's been levelled against that my approach, which is why use foam if liquid works, is that I would advocate diluting 0.2% STS with either normal saline or water for injection and making it 0.1%. And my some criticism would be that, well, if you're going to go off-label, Haroon, why not? What's the beef against foam?
Yeah, I think there is for quite a few years now, and increasingly when you look at the literature, there are many renowned clinicians who are saying that 0.1% STS is possibly the more ideal concentration for treating spider veins. And again, that's been cited in guidelines for many years. So when it's cited in a guideline like that, then it does give some credence and some potential backup for clinicians who are using it. And
yes.
I think if it came to the crunch in a court of law, that there is enough published guidance by learned societies that would say, well, it's written in black and white there that 0.1 to 0.2 is the recommended concentration of STS, which is what they say in the UIP guidelines, but it's been in the European guidelines for many years.
Yes. I suppose, Richard, it's not a question of black and white, is it? It's a grey area. And I suppose it depends how far you are departing from the licensed use and the guidelines.
Yes.
And I would advocate that if you're diluting 0.2% with water for injection or normal saline, you're not departing excessively from the guidelines. Whereas if you then make it into foam, that is a more serious departure. What would you say to that?
Because yes, I think that's right. And in terms of dilution of STS, it's always better to dilute it with normal saline.
Yes.
Because of the critical micellar concentration, it remains above that level. So you're going to be sure it's in its micellar form and therefore more active as a detergent.
Yes.
but the European guidelines don't mention foam for treating spider veins.
No.
But now this UIP, I mean, does the UIP trump the European guidelines? I don't know, but it is now. It is now there, and we could have a whole conversation about what guidelines mean medico-legally, because they are a guideline. They're not the law. They are a guideline based upon evidence or upon, more often than not, learned opinion, a consensus opinion from people who allegedly know best.
Yes, that's right. Allegedly. Right. So, does that take us neatly onto medical legal considerations and consent, Richard, or would you like to talk about something else before we get onto that?
No, I think that sort of covered the situation. I think the foam versus liquid is not an answer we're going to be able to, or not a question we're going to get an answer to easily. It was a shame that French study was stopped, because I think that would have provided some very useful information and some data for us. But that's the situation currently.
Yes. Well, that's great. Thank you for that. Richard, I now know how to look at a Cochrane review a little bit more systematically, with a bit more science behind it. Thank you so much. And I'm sure a lot of people watching this video, they may not admit it, but they'll now be able to identify the important bits of a Cochrane review, because, as you say, they're pages and pages and pages, aren't they, usually?
Yeah. I've done quite a few Cochrane reviews myself, I think 9 in total now. And I remember, because I used to be a dentist, and we had the oral health group of the Cochrane based in Manchester, and I was told, do a Cochrane review. It's a very easy publication to do. And I can tell you that they're not straightforward to do, but they're very useful when they come to fruition. But there is a lot of stuff to read, and if you fast forward through the Cochrane review to the tables like that, you'll interpret them much more straightforwardly.
Well, thank you very much, Richard. Right. So, medical legal. Oh, so you can't answer the question. STS, we should dilute with normal saline if we're going to dilute it.
Yes.
Polidocanol, it doesn't really matter, does it? You can dilute.
Doesn't really matter, because the critical micellar concentration is a lot lower with polidocanol anyway, because it's a different molecule completely. Yeah.
Yes, and because now we've got 0.2% polidocanol in the United Kingdom, there's probably no reason to dilute that at all.
There should be no need now. No.
Now, Richard, this is a sensitive subject. Some of my colleagues will buy the more concentrated form and dilute it, I think really for economic reasons, because it's cheaper. What do you think about that? Is that naughty?
Yeah, I have to say it is really, because
we're not naming anybody, so we can say it's naughty.
Because there are proprietary concentrations produced at the concentrations they are produced at, because they are the ideal concentrations for treating the various vein sizes. It would be looked at, I think, as it's definitely an off-label use when you do that. And to be honest, in comparison with RF and laser fibers, sclerosants are really very cheap, and so if you have a couple of ampules of sclerosant you have to throw away because they get out of date, you've lost very little.
Exactly.
It's probably better to stick to the proprietary ones. And I have to say, from my own clinical experience, when I've been certainly, I remember being involved in a local anaesthetic trial many years ago, and we had to dilute the local anaesthetic according to body surface area. And the medics I was working, well, even myself, we weren't very good at working out what the dilutions were. The anaesthetists were the best. Anaesthetists could just take a thing, and they just, because they're diluting things all the time. But most clinicians are not very good at dilution. And the risk is you either don't dilute sufficiently and you've got too strong a sclerosant, or you over dilute it and your sclerosant is ineffective. So it's much better to stick to the proprietary concentrations.
Exactly. And of course, I think if you're doing that, you really ought to tell the patient, and they're not going to like that, are they?
Potentially not. I mean, some patients couldn't care less, but yeah,
No.
so increasingly, a lot of patients are a lot more savvy about what's happening to them, quite rightly too.
Yes.
So yeah.
Yes. Well, tell us about consent then and the medical legal aspects.
Well, I just there was a study published that just came to mind when we were talking about what we were going to talk about. A study from the States which looked at, this is all vascular surgical litigation, but published just last year actually. The first thing that surprised me was it was over a very long period from 1984 to 2018, and there is some register that they were able to search in the States. But what surprised me is there are only 144 cases, which I thought was quite low, given what we hear about this litigation in the medical profession in the States. But from those 144 cases, they had 41 that involved varicose veins and 11 that involved spider veins. And some of the key points were the injuries that occurred to patients were skin ulceration, 85% in spider veins, which struck me as quite high. So that perhaps indicates some lack of maybe methods that the doctors were using, or maybe too high concentrations that they were using. Nerve damage, which we're familiar with, can happen anywhere. And then emotional distress was a relatively small number. It did say that only 20% of them were ruled in favour of the plaintiff, which is what the United States call the claimant, which is what the legal profession would call it here. And only 4 of those were for spider veins. But quite interestingly, on the next one was the reasons why these cases were brought. And by far the biggest number was not giving sufficient information about the post-procedure complications, which we all know can happen and will happen. And that is a very, very important part of the consent process.
Yes.
And it was when you muted this conversation, I said, can we just have a little bit of a talk about consent? Because we go to sclerotherapy courses quite frequently, talk to conferences, and I wouldn't say the number one question, but it's a very common question that we get asked is, have you got a standard consent form that we can use for sclerotherapy? And we say, my response is always, sadly, no, we don't have a standard consent form because consent is not standard, really. Consent is it's a process rather than a single point in time signing a form. And I think that's what people need to understand when they talk about getting consent for their procedure, albeit for treating spider veins or for treating larger veins or whatever they're going to do, is that it's a process or a procedure from the time that the patient expresses a desire to have some treatment to the time the treatment is actually undertaken, and the patient has the right to withdraw their consent at any point in that process. And a consent form, I did quite a lot of medico-legal work before I stopped as a clinician, and I have to say, in all the cases that I was involved with, the barristers were not interested in the consent form at all. What they were interested in is that recorded somewhere, at least in more than one instance in the notes, was that the patient had been informed of the treatment they were having and the risks that they were involved in that. And the defence agencies generally will say a consent form is useful to record that the decision has been made and recorded at that point in time, but it's not a substitute for a dialogue that you should have with your patients
No.
before, during, and after the procedure.
Yes. I think you're absolutely right. I mean, I think it's one of the longest part of the consultation is discussing what's going to happen, the pros and the cons, the option of doing nothing, the likely outcome, the side effects, the fact that they're going to look worse, and putting those side effects and complications in the context of that particular person. Is that
Yes.
person about to go on holiday, and do they realize, have you emphasized sufficiently that their veins are going to look worse after treatment? That may be less important to somebody in the winter when they're covered up and they're not planning to go on holiday. I think it's very difficult. And some people say they didn't realize, even though when you've explained things to them, they are going to look worse, you will get brown marks, there's a small risk of a scab. They say, I didn't remember that. I don't recall that. So, yes, the consent form then is helpful. But yes, you've got to document these things. It does take time.
And obviously with the in obviously English and Welsh law, I don't know a lot about Scottish law, but the Montgomery case has changed things a little bit in terms of having to make sure that you tell the patient of all the material risks that are significant to that individual patient, which might not be the same as the patient that came in before. So you've got to tailor the risks to that individual person.
Yes. Tell me, Richard, should we be mentioning the possibility of death? I mean, it seems a bit drastic to say there has been a report of somebody dying after sclerotherapy. Is that something seems like it is a significant thing that does happen, and it does seem that everybody would be interested that would be a remote possibility. Do people mention it?
I don't think many probably do mention it. There are obviously some serious risks of harm with sclerotherapy. Probably more, although they're still very rare events, but you've got TIAs and strokes and VTE events, deep vein thrombosis, pulmonary embolus, albeit they're not common risks at all. But there are a number with both agents, with STS and Polidocanol, there have been deaths reported over the years. Sometimes they can be attributed to the agent, sometimes they may be more down to the comorbidities associated with that individual patient's health. But it's difficult. And I used to have this conversation with anaesthetists a lot, because we know that there is a risk with a general anaesthetic of about, I think it's about 1 in 200 or 200,000 incidences of a general anaesthetic can result in death. In a young, healthy person, that's going to be significantly less. But the anaesthetists got a bit ruffled, and I think they all were saying that death is a possibility with a general anaesthetic. And I don't know. It's difficult. It is a minuscule risk, but it's there. It is a risk. So it's difficult to know. I mean, the two agents, as we've said, they're both the two agents. They both have similar sort of operating properties. Their incidence of adverse events of the more commonly occurring things is quite similar. STS is potentially slightly more prone to allergic reactions than Polidocanol, and that's been shown. There's been a couple of large-scale registry studies that have looked at adverse reactions, which I've not put in this presentation, but I can certainly provide you the references for that. And Polidocanol has, because it's got some local anaesthetic properties, is negatively inotropic to the cardiac muscle. So that's where that seems to be the mechanism whereby it's caused cardiac arrest. So it's a little bit like some of the local anaesthetics, particularly some of the long-acting ones like bupivacaine, which if you inject that intravenously, then you're quite likely to see a cardiac event occurring after it's been injected. So yes, they are risks, but they are so small. But I don't know. I think if you were being belt and braces and doing it by the book, it's something that you should mention, albeit it's extremely low risk.
I wonder if anybody would have microsclerotherapy if death
Well,
was mentioned as a possibility.
would you do anything if you knew, with all the risks? But
Quite, yes.
I mean, that's a decision for individual clinicians to make.
Yes,
but,
yes.
There's been, it's in the handfuls of numbers of deaths following sclerotherapy compared to the millions of administrations of the drug. So we're talking, very, very small.
Yes, yes. Okay, so it's dissatisfaction. It's the consent process. Dissatisfaction with the information that was given is the major problem.
Yes.
That slide identifies.
Yeah.
Interesting.
So it is very important to warn of all the risks.
Yes.
And I think that's where, I mean, if you don't have necessarily a standard consent form, but I think a lot of practices will have some standard information that they'll give out to the patients that will cite all of the known risks associated with the procedure.
Yeah.
And whether the patient reads it or not is another thing. But I think if you do that, you've got to write it in a form of words that the patient is going to understand as well. Because I have seen some information sheets which they're written in clinician speak, and I think a standard patient would fail to understand them.
Yes, and just from my point of view, I always thought it was important not to do the consultation and the treatment on the same day for that very reason, the consent process.
Yeah.
I think you're more likely to be able to defend your position of having properly consented a patient if you see them, do a consultation, give them the information, and then they voluntarily come back on a subsequent appointment to have the treatment. Yeah,
so I've written big letters here on my notes I made for this. Time to reflect is important.
Time to reflect, absolutely, yes.
And then you reconfirm their agreement to proceed with the procedure before you do it.
Yes.
They're still within their rights to withdraw their consent.
Yes, absolutely, yes. Great, okay. Anything else, Richard?
So I was we've talked a little bit about off-label use. So I just had a couple of slides about off-label use, because we said that using foam in the low strengths, which are not licensed for foam, would it be an example of an off-label use. And what off-label is referring to, the labelling that comes with a drug is something that occupies an inordinate amount of time for us as companies to get right, and it has to be obviously approved by the various agencies where we apply to have a license to distribute the product. And it's something that a lot of clinicians are not really aware of, but it's written for them, is something that's called the Summary of Product Characteristics, or the SPC, or the SMPC, it's often referred to, which essentially is like a written monograph of the medicine. And that is part of what the regulatory agencies refer to as labelling. So it's a document that sometimes it can be quite long. I mean, if you look at the SPC for Botox, it goes on for pages and pages and pages. But it's well worth a look if you've never looked at the SPC for any drugs that you prescribe on a regular basis, because it does lay out in now a universally accepted way how these are always laid out. And it's essentially what the leaflet that comes inside your medicine is based upon. So the patient information leaflet is based upon the information that's been approved in the SPC. And that will list the indications for use of the drug. It will list the known side effects and adverse events that can occur with the drug, and the frequencies at which they're known to occur at the time of producing that particular document. So it is a very useful document, and it will give you information on how that drug is administered. So for the sclerosants, it tells you how they are administered and what to use on which veins and so on. So it's so if you're using a drug in a way that's not listed in that SPC, then you're using the drug off-label, so it's not within the labelling. And in terms of whether you should use something off-label, if it's in the patient's best interests, then it is, I think, considered acceptable, provided they've been appropriately informed and consented about that use.
Yeah.
So that's where sort of where off-label use sits. And I think the next slide is I just looked up what the situation is with doctors using, and I think this will be the same for any registered healthcare professional. In the good practice document that the BMA produce, not the BMA, the GMC.
GMC.
Produce, yeah.
Regulating doctors and
tells
protecting patients.
Yeah, yes. I think it's the other way around. It's protecting patients and terrorizing doctors, isn't it? I think
exactly.
A lot of people would say. But it gives you some guidance in there about using an unlicensed product, which essentially is what you're doing. If you're using it off-label, you're using it as unlicensed. So it's got to be you've got to be satisfied that there's evidence and you've got the experience of using that product off license, and that you take the responsibility for prescribing it, which essentially is what you're doing when you're doing sclerotherapy. You're prescribing that drug for that individual patient.
Yes.
So, and you have to make it clear that you've recorded in the patient's notes that you've used it as an off-license, off-label use. So it's a tricky one. Medicines are used off-label all the time, and medical devices, exactly the same. But when when you start to see there's bodies of published evidence that support that use, then there can be more support if the worst came to the worst and you had to defend yourself.
Yes.
You did mention sorry.
Go ahead. Go ahead.
I was just going to say you mentioned in your Facebook post about the use of the spelling of licensed.
Oh yes.
With an S. Is it with an S or a C? It's something that I went to grammar school, so it was drummed into me of what the difference is. A license with a C is the noun. A license with a C is a noun. With an S, it's a verb or an adjective. So it's the same with practice and practiced. Yeah.
So listen, a lot of people use sclerosants off-label, hand veins, arm veins, veins on the breast.
Yes.
What about on the face? That's always made me extremely nervous. I know that there are esteemed colleagues in the United States who say that foam sclerotherapy, liquid sclerotherapy can be used safely on the face. I've always been very anxious about that. I've read the publications, but I've never actually treated any facial vein with sclerotherapy. Am I being silly? Should I be a bit more bold, grow a pair?
I think you're being appropriately cautious, because we know from receiving adverse event reports that some of the most horrendous adverse events occur when facial veins have been treated with sclerotherapy.
Yes.
Just because of the nature of the blood supply in the head and neck. It's a very richly supplied area with blood vessels, and although there is some standard anatomy, there is a lot of non-standard anatomy in the blood vessels of the face.
Yes.
And arteries and veins will run very close to each other. There will be arteries in some people where there shouldn't be arteries, and so the risk is just too great.
Yes. Well, it's nice to hear it from somebody, an oral surgeon who knows the head and neck anatomy better than most people.
Yeah, and I've come across arteries in the face which you didn't expect there to be. Yeah. It's just not worth the risk. As we would always say, don't treat below the malleolus of the ankle, because as the blood vessels get into the foot, the veins and the arteries run very, very close to each other, unless you're absolutely certain that you're in a vein, then just don't do it, because the risks are too great.
Yes.
Because
yeah.
if you inject into an artery, then the effects are pretty catastrophic, because that artery is supplying oxygenated blood to the tissues, and you're going to basically cause an infarction of the whatever that artery is supplying, which at worst could be a small segment of skin, at best small segment of skin. At worst, it could be the globe of the eye, for example. So it's not very pleasant.
Good. Okay. Well, but that's reassuring to know I'm not being unnecessarily chicken or unbrave.
No. I mean, there is a lot of unlicensed use in sclerotherapy. We've talked about dilution. We've talked about foam for spider veins, non-leg veins, as you've just discussed. Certainly not in the face. Other areas of the body, provided. I mean, I think if you're certain it's in the vein, the general rule is with sclerotherapy is if you can see it's a vein, i.e. the colour of the vessel, or if you can't see it, you've got some imaging to see it, so ultrasound imaging, preferably Doppler ultrasound, so you can be sure it's a vein and not an artery.
Yes.
Then I think cautiously it can be used elsewhere, but it's an off-license use. What we know is it is being used substantially now for treating vascular malformations, whereby previously they were using agents like absolute alcohol, bleomycin, and some quite nasty agents. Sclerosants are much more gentle, but they don't come without the potential risk of adverse effects. But the nature of vascular malformations is every single one of those is different. They're often only treated because they are putting pressure on some other vital structure, or they're bleeding spontaneously because of their proximity to the surface of the skin, and they've got to be treated. And surgery is often not an option. Sclerotherapy is a much gentler option, and detergent sclerosants are probably a better option than some of the more what's the word? Aggressive agents like alcohol and so on.
Yeah.
And similarly, esophageal viruses are being used for increasingly as well, because again, they're often life-threatening situations where you get bleeding varices, often in terminal liver disease, and it's a matter of saving someone's life. So it's a justified off-label use.
Of course. Well, that's good. I think you've covered most of the questions I had. Is there anything else on your list of things you'd like to cover, Richard?
No, I don't think so. I think that was the brief, wasn't it? So I've tried to stick to what we'd agreed. As I said, we can talk for hours about some of these things, but I think that's enough information for most.
Listen, Richard, thank you very much for giving up your morning, and
You're welcome.
Of my circumstances, it was very kind of you to change the time. As I say, I will embarrass you. You're probably the go-to person if you've got a query about sclerosants and sclerotherapy. Would you be happy for me to put a link to your email address in the description below?
Of course, yeah. We're always happy to help you.
That's great. And would you be happy for me to share these slides? Because I know that some of them are quite detailed, and people will like to see them perhaps and study them with a bit more time. Are you happy for me to share?
Yes, of course, yeah. Yes, of course,
great.
Yeah.
And of course, people who want to meet you can come to the BAS meeting in May, because you're giving a presentation about, guess what? Sclerosants.
Yeah, sclerosants, yeah. Yes.
Well,
looking forward to that.
I'm really looking forward to catching up with you, having a chin wag over a cup of coffee and shaking your hand, because I haven't seen you for years in person. It'd be really nice to see you.
Yeah, it'd be nice to see you again, yes.
All right then. Well, thank you very much, Richard. That's very kind.
You're very welcome.
And take care and enjoy the rest of your day.